Okay, good evening. And after all the hassles, we are talking to each other.
Yeah.
And as it was decided, I am going to talk on intraocular infections, particularly, especially in hematological patients. And we will see one by one what are the problems. Actually, first of all, a brief introduction about ocular tissues or what is intraocular. Actually, all ocular infection can be classified into two categories. One is extraocular or adnexal, and another is intraocular. Intraocular may be viral, bacterial, fungal, or protozoal. But mostly it is viral, bacterial, or fungal. Therefore, we are only talking today about intraocular and only viral, bacterial, and fungal. Protozoals are very rare, and in our experience here or elsewhere, I have not seen any protozoal so far, intraocular protozoal infection in immunocompromised yet. But these three are seen and on the rise, actually. And a brief look at the ocular structure. What is intraocular and what is extraocular and what is anterior segment and so on. So there are two cavities inside the eyeball. One is vitreous cavity, that is larger one, and another is anterior segment, that is our anterior chamber, that is the smaller one. And all the purple arrows are the structures that are intraocular, that is ciliary body, iris, lens, and anterior chamber, choroid, retina, and optic nerve. These structures are intraocular structure. And all the green arrows all the structures that are indicated by green arrows are extraocular tissue, that is conjunctiva, cornea, and sclera. So now we are clear what is the intraocular and what is the extraocular. If anything happened to this purple arrows structures, that is intraocular involvement, and anything if happens to the green arrowed structure, that is extraocular involvement. Now, the intraocular infection can be in the form of anterior uveitis, that is, if the ciliary body, iris, pupil, or anterior chamber is involved, it is anterior. If anything happened to these three structures, that is choroid, retina, or macula, that is chorioretinitis or posterior involvement. And involvement of vitreous body in the inflammation is endophthalmitis. But anyway, eye is such a close compartment that anterior uveitis, chorioretinitis, or endophthalmitis, including endogenous endophthalmitis, usually progress into each other if any one of these is involved. And so this division is largely artificial in most of the cases. One involvement, anterior uveitis, if it is infective, no doubt it will progress to chorioretinitis and in the endophthalmitis. And particularly in hematological disorders, where it is assumed that patient is already immunosuppressed, not even if they are not on any immunosuppressive agent, the disease itself involves the immune system, most of the diseases of hematology, and it is a grave emergency. Intraocular involvement in hematological disorder is the grave serious emergency. And now I am coming to directly to endogenous endophthalmitis. That is the most common type of endophthalmitis that is found in systemic diseases. Other are traumatic and post-operative. Post-operative means after cataract surgery. That is not the topic of discussion today. That is entirely different thing. We are concerned about the endogenous endophthalmitis that spreads through the blood stream. So why we should study all this endogenous and all these things? Because endogenous endophthalmitis is certainly blinding and potentially life-threatening. And only good thing coming out of this, it is it is very rare. Now first come to the viral intraocular infections. And this potentially life-threatening one, most of the studies coming out of hematology also, and no doubt of endophthalmitis studies itself have recorded the increase. We will see later in this presentation. The most common type of viral infection in eye in immunocompromised or in hematological disorders or kidney transplant or solid organ or transplantation, BMT, etc. is CMV, cytomegalovirus infection. And Weller is the credited. Weller is said to discover this first time discover this cytomegalovirus and awarded Nobel Prize for this. This is the first report of ocular involvement by the cytomegalovirus infection in 1964. The seroprevalence all over world is 100%. In India, it's 100%. In homosexual, it is definitely 100%. In rest of the population, it varies between 90 to 100%. The terms used in CMV retinitis or CMV infections are very important. If you search the literature, these terms are used differently in different literature, and it creating a lot of confusion. So seropositivity means there is IgG antibodies are present in the serum of any individual. It means at least that person is infected once in his lifetime. Primary infection is actually nothing but the first infection, or in the immunocompetent, it is totally asymptomatic. And it also implies that there is no prior immunity, and after this infection, the IgM is transient. IgG antibodies comes into the bloodstream. Now, the latent infection. Latent infection is nothing but this primary infection in immunocompetent become dormant. You can't get any evidence apart from CMV IgG into the bloodstream or in any individual. Viral genome is even not detected by PCR if it is latent, and this is the case with immunocompetent. By cytopathology, you can't culture the virus. Even by PCR, only IgG you can detect and nothing else. Secondary infection is nothing. Secondary infection means the primary infection when become active, means that this latent or this dormant CMV virus now start replicating, whether in immunocompetent or in immunocompromised. There are various factors that is responsible for this transition from latent to secondary. And in the secondary infection means where virus is actively start replicating, here you can detect the viral genome by PCR. And the super infection, okay, now these are all these terminologies, but we are concerned with these two things. Latent infection, that means primary infection happened. That is the case with every individual in the world. And in immunocompetent, it goes dormant. There is no evidence of any infection apart from IgG antibodies. Now this latent infection or the infection we have encountered first time, if it started, virus become non-dormant, virus become active, and it has started replicating, that is called the secondary infection. Secondary infection does not mean the second infection. It is the reactivation of the first infection. In immunocompetent, once infected, there is on and off asymptomatic shedding of CNV may happen, but usually it is asymptomatic. On and off, virus may get activated and start replicating, but automatically it gets dormant. And this is the cause of the, and in this way, this virus keeps their population or keeps its replicating cycle in the nature in immunocompetent. And this horizontal transmission is ensured that this virus gets passed on from one generation to another. And if by sexual preferences, homosexuality is the most common cause of this horizontal transmitter, apart from the mother to baby. What triggers are there for the activation is not known. In immunocompetent, it's a cellular immunity that controls the viral replication and induces the latency. And this is the summary of what I have told. The host is immunocompetent host is infected, latency is there is induced, and the virus is kept into the CD34 progenitor cells in the bone marrow. and some evidence about that vascular endothelium also store these viruses. But if reactivation happened by any chance, then in immunocompetent, it is asymptomatic and automatically gets again into the inactive mode or latency induced. But if immunocompromised, a lot of problems happens, as you can see. The CMV retinitis is the most common CMV disease in the immunocompromised or overall CMV. This is the most common CMV disease, but it can infect, it can make any organ diseased. As you see the list from top to bottom, any organ can be infected and can be attacked by the CMV once it's get activated. Now, therefore, I am just talking about this CMVR. CMV retinitis is the purely clinical diagnosis. And the one feature that is the constant is the full thickness retinal necrosis with retinal vasculitis, either venous side or arterial side. But these white areas, you can what you are seeing on the screen is the full thickness retinal necrosis. And because of vasculitis, there may be hemorrhages and exudates, etc. And this this appearance is what is called tomato ketchup appearance. You can see it is just blood is splashed as like it is the tomato ketchup has been splashed on something. And this is purely clinical diagnosis, but only way to confirm that by the way of CMV PCR, either on blood or ocular fluid. If there is we can get the genome of the CMV virus in any fluid of the body, it is the confirmatory that CMV is replicating and it's a secondary disease has happened. This is the brief about how this viral genome gets activated. And actually, in very brief, actually in the immunocompetent, this CD34 cells, inside the CD34 cells, there are human cellular proteins that binds to the viral genome and in latency is induced. But by any cause, when these CD34 cells are differentiated into dendritic cells or macrophages, these proteins fail and virus start replicating, and this is the reactivation of the virus. This is just, it has been shown that this is CD34, this is progenitor cells in latency, but whatever factors, these are the factors, these are a lot of human normal cellular proteins binding to this viral genome and the replication is stopped. But whenever this balance is disturbed, this dendritic cells or macrophage transformation happens and this virus becomes activated. CMV was the disease of HIV patients before 2000. But after 2000, the load of CMV has gone almost negligible in HIV population because of heart. But on the contrary, it is increasing in immunocompetent non-HIV persons. Non-HIV persons immunocompromised by mostly by the drugs post-transplant or for any other regions where the immunosuppressions are given. And it is mainly nowadays a mainly problem of the immunocompetents or immunocompromised, non-HIV immunocompromised. And as we can see, these are the this is the timeline, and actually how from the first case to the 2000 we have progressed so far. Now, actually, this one in immunocompromised, getting CMV reactivated is one thing. But nowadays, what is happening? We are giving a lot of antiviral prophylaxis. When it becomes our knowledge that after post-transplantation, intense immunosuppressive are given, CMV infections are very common. CMV disease is very common. Then we started giving antiviral prophylaxis, and just after transplantation, we started it. But it has given rise to a new type of phenomenon. As far as antiviral therapy is going on, there is no symptoms, no clinical symptoms, no disease. But as soon as this antiviral prophylaxis stops, when this immunosuppression gets down, and we think that now the CMV risk is decreased, as soon as we stop this antiviral prophylaxis, the risk of this late onset disease starts. Even when this immunosuppression gets down, but as if we have given the antiviral prophylaxis, the late onset disease, this is the new subset of the disease comes into the picture. As soon as antiviral prophylaxis is stopped, even when immunosuppression is not so intense, but the CMV become active and CMV disease happens. So this is the actually complication of antiviral prophylaxis we have seen, and this prompted us to give instead of continuous prophylaxis just post-transplantation, preemptive therapy. As you can see, we start antiviral therapy only when we do a regular serial PCR testing, and as soon as we get first sample positive, we start antiviral therapy for some time. Then again we get negative PCR, then we stop. If again it becomes positive, we give the antiviral therapy. And this late onset CMV disease, once prophylaxis was started, antiviral, we thought that it is controlled now. But nowadays, the late onset CMV disease is observed increasingly, and this is not trivial phenomena. Just see the figures. It is the load is very high in hematopoietic stem cell transplant patients of the late onset, and in solid organ transplantation, it's almost in all patients. And this problem with this late onset disease is it is the atypical manifestation, and it is very difficult to evaluate clinically and diagnose clinically, because features are not as typical as in early onset disease. Now, I'm coming to this antiviral treatment. I'm sorry, actually, I could not see you the many of the fundus photographs of my patient, because actually Archit is knowing we have our one of the article is getting published, and it is in publication process. So those images, it is not possible to show here. I'm sorry for that, actually. Actually, what is the aim of antiviral treatment? Aim of antiviral treatment is only one, that reinduce the virus latency as in immunocompetence. We can't eradicate, we can't get rid of virus. Anybody in the world cannot do this. We only, whatever viral replications have been started, we can stop the replication and induce the viral latency, whatever treatment modalities we have now, as of now. And that is the reason the most of the drugs are virostatic only in the nature. And one thing is the antiviral agents, and another thing, simultaneously, recently we have tried to increase the cellular immunity, or reinforce the cellular immunity once again, so that virus is made latent by immunity itself. Antiviral is one thing, and there is two-pronged approach, you can see. But cellular immunity reconstitution is still in infancy, and the antiviral drugs are the most common way of controlling the viral replication. And along with this, if we can preserve the vision and reduce the risk of CMV-related visual complication, that is very nice. But our aim is saving the eye globe first, rather than preserving the vision, because that is not possible in most of the cases. Preventing the eye globe, and so the disfigurement of face could not be there. That is our main aim. There is no guidelines available for CMV retinitis treatment, and the most common way of treating these patients are the antiviral agents by way of intravenous infusions, plus or oral, and along with intravitreal antivirals. And there is a lot of actually, given the patient's condition at the time of diagnosis, at the time of treatment, we have to make many choices, but the gold standard is give the systemic as well as intravitreal both. But sometimes giving the systemic is not possible because of many of reasons. Sometimes intravitreal cannot be given because patient is not in such a patient is in ICU in CCM and patient cannot be shifted to the OT, etc., etc. But anyway, this is the standard of treatment. The agents available for this CMV retinitis treatment are these: ganciclovir, valganciclovir, and valganciclovir is given since it is oral. It is now the most preferred drug given systematically. And ganciclovir was earlier, when valgan was not available, was given intravenous. And the three drugs, those are in red color, is reserved drug at present actually. And all these are approved, FDA approved. But this last one, this final one, leflunomide is not approved, but it is off-label used particularly in India because of cost considerations. I will discuss in coming slides. So these are the agents available, and valgan is the most commonly used for systemic application, and ganciclovir is the most common agent used intravitreal. These are the doses and of these drugs, and actually ganciclovir implant and fomiviricin is not available commercially now, so we are not going to talk about this. Actually, the ganciclovir is the very good drug for CMVR. Only thing, myelosuppression in hematological patients. The use is always, the difficulty in using all these drugs and thrombocytopenia associated. So in many a times these drugs create a problem of this sort. But what is the good? Better things of this drug, it is active against all herpes viruses and simplex zoster, EBV, and CMV all. And this is the drug that at the initial phase of the viral replication it attacks that viral kinases, or it binds to the viral kinases, and triphosphate, ganciclovir triphosphate, that is active drug, and the further cycles are broken. This cycle is broken and viral cannot replicate further. But myelosuppression is the big issue with this drug. Actually, valganciclovir is the prodrug of ganciclovir, and because of oral route, it can be given through oral route. The compliance is very good, and the side effects, our experience also in this center, that side effects are not as common with ganciclovir given intravenous. When valganciclovir is started, patients also look comfortable on visits. So reason I don't know. But resistance is also repeated frequently. Our experience is not, there is no resistant cases we have seen so far. We have seen in last 3 years, 6 cases of this CMV retinitis, and all these non-HIV cases. One case was HIV positive, but that was very serious patient, and I think he is no more now. But the majority of patients were 6 patients were 2 cases from hematology side and 3 from hematocytes, and 3 from the renal post-renal transplant. And actually, we don't have any ganciclovir. All are treated and all are cured with ganciclovir only and valganciclovir only. And this phoscornate is reserved for the ganciclovir resistance, and actually phoscornate acts upon this final stages of the replication, and it directly inhibits the DNA polymerase of the virus, and therefore it is more effective and more resistant to the resistance development, because it directly attacks the polymerase. So since genome is destroyed, so the possibility of creating resistance from the virus is almost getting negligible. Actually, cidofovir is a very good drug, but the problem, this nephrotoxicity. So here also the nephrology persons are very averse of this drug, and even the many trials have been stopped because of very high high degree of nephrotoxicities with this drug. And from ocular side, one problem is this: there is the persistent anterior uveitis. The inflammation does not go away. Virus may be gone away because of this drug, since I have not used this drug. But the reports say that even everything is fine, the anterior uveitis does not resolve, and the low-grade anterior uveitis is present as far as this treatment is going on. So at present, this is a barely used drug. Actually, this is leflunomide is the off level at present, and it does not attack on the viral genome. This attacks this inhibit the virus assembly, and this inhibition lead to the non-infective or you can say dead particles or non-active particles of virus being generated. It is actually used off-label in Indian patients by Indian because of this. This is much cheaper than the earlier drugs, and also the long-term suppression is reported in drug-resistant. That is, the drug-resistant cases also respond well to this drug, but there is no trial available. Just a few cases are reported from India. So we have to wait for this drug. Ocular, there are some benefits. If CMV retinitis is there, along with systemic, you have to give the intravitreal because of obvious advantages. The high concentration of drug can be reached directly at the target. There is minimal systemic toxicity. Even when you cannot give the systemic treatment, we can continue with intravitreal, and that is the very good thing actually in many of the cases where I mean myelosuppression or so on. Intravitreal does not leak into the systemic circulation, and there is barely any systemic toxicity. But implants are no longer available commercially, but that's the reconstituted drug acts very well, and it gets very good results. But only problem is that other eye cannot be protected. In normal eye or uninvolved eye, it does not give any protection, while systemic treatment, as you know, it gives the protection to whatsoever degree to both eyes. Actually, fomiviricin is not available commercially nowadays. So now it is the drug treatment. Now, as I say, people said why it is the cellular immunity that induces the latency. So why we are giving drug? Why we cannot upregulate the immunity itself? That again, if virus is now replicating because of depressed immunity, it can we can upgrade the cellular immunity that it can again go into latency. And there are few options that is tried and with good results, but prospective trials are not there. One is the T cell mediated immunity against to achieve T cell immunity. This is the adaptive transfer of CMV specific donor cytotoxic T lymphocytes. This is given this is the first reported intravenous, but few people have given intravitreal also. No controlled or prospective trials are available, only case reports. It is administered intravenous, this donor cytotoxic T lymphocytes. And first it was reported for only non-ocular cases, non-ocular CMV disease. And it was effective in, people have shown it is effective in decreasing viral titers, and PCR copies are getting low after this treatment. That is indicative of the control of infection. But one single case of long-term success, only one case is reported into the CMVR, and that also report the 6 months, up to 6 months, there was no recurrence. That is a very good period if there is no recurrence of the transfer of this CMV specific T lymphocytes that was given intravitreal. And this was the case. Actually, it achieves the full You can see the top ones are the pre-intravitreal injection, and bottom ones are the 6 weeks later after this intravitreal injection. And you can see this active areas have completely gone out, and this retina is relatively very healthy. And as per researchers, up to 6 months they have reported there is no recurrence was noted. And one actually people gone further and they say why we are getting involved in all these things? Why we don't kill directly the latent the cells which harbor the latent viruses? This is still a experimental thing, and this is people are doing in the lab. No clinical human clinical trials or human case reports are reported. Vincristine has been shown to selectively kill the latent viruses or the cell harboring the latent viruses in human body. But we have to wait further for getting anything to be done into the human beings. And as you know, the combined approach, including the prophylactic as well as the treatment, as well as the cellular immunity enhancement, all those the combined things may be the most appropriate approach, but practically possible or not possible at present, this is another issue. Drug resistance, the most common top 3 reasons for drug resistance is the CMV treatment itself. The prolonged, as you can see, the prolonged CMV treatment or previous antiviral drug antiviral CMV drug exposure or recurrence. These are the commonest cause of the resistant generation. And another thing, if initially if viral load is very high, then also it is possible to the resistant strains becomes after some time of the treatment. Actually, this is important. How resistance is created? Actually, what happens? This in the ganciclovir resistant virus mutate the kinase genes. And when it is get mutated, actually this kinase is no longer the kinase ganciclovir involved no longer remain useful. And now because of that, this mutated kinases, ganciclovir cannot bind to these new kinases, and the virus start replicating again, as you can see. Okay. Because now the mutated kinases don't bind to the ganciclovir, and the replication again start. Phoscornate is the actually very serious problem. Phoscornate resistance, if it is there, it is it gives resistance to all the available drugs. If phoscornate resistance is there, no drugs will work in any patient. And how it works? Actually, what happens? This polymerase, actually phoscornate acts on this polymerase, and this becomes mutated. In this case, when it gets mutated, actually this polymerase becomes able to use other viral kinases that is not targeted by any drug. And using those viral kinases that is not meant for in normal circumstances for CMV attachment, but CMV start using those kinases, and the virus again start replicating, and in this way it confers resistance to all the anti-CMV drugs. If phoscornate get this UL54 viral, whenever virus becomes able to mutate the UL54 or polymerase genes, this is very serious problem actually. And you can see longer the duration of antiviral treatment, the more the incidence of resistance. And this is the problem. The second one, you can see if polymerase get mutated, all the drugs become ineffective. And if kinases only gets mutated, only this ganciclovir becomes ineffective. But this is the almost you can't do anything if polymerases get mutated. And these are the definitions you can read. And when it is the resistance when it is refractory actually. Whenever refractive end organ or resistance is there, we have no choice but use reserve drugs, and these are the usual drugs, but we no longer work. We are only left with foscarnet and cidofovir, and if foscarnet is not working, nothing will work. Now these two drugs have been developed and they are reserve drugs also, letermovir and maribavir. Actually, they don't attack genome. They act after DNA synthesis completed, and they attack the packaging. Okay, they packaging and nuclear, they attack on these targets. They stop the packaging of the genomic viral genome and creation of in this way they stop the creation of active viral particles. And this MBV, they actually stop the egress from the inside the nucleus. It cannot come outside the nucleus, viral particle, and cannot get into the circulation. In this way, these acts when the genome has been mutated, but resistance is also reported with these two drugs also. And our approach is we use the simultaneous application of systemic as well as intravitreal antiviral therapies. Only antiviral, as I have said, injection cannot there is no protection to other eye, and virus is in the circulation. No doubt, if we don't protect other eye, it will get involved sometime in future if one eye has been involved. So intravitreal alone will not work in long term. Only IV treatment. By IV route, actually drug concentration inside the ocular cavities are not, it is most of the cases suboptimal, and it had to be supplemented by intravitreal injection once virus is settled and replicating inside the eye. So far, we have not encountered any issues of myelosuppression or toxicity or resistance in hematological patients or solid organ transplant patient or BMT patient. So, and all the patients are doing well at present also. And though no recurrence was also noted after the first episode of treatment. This is the viral, and now, as I said, the bacterial and fungal. The bacterial and fungal infection manifest mostly by endogenous endophthalmitis. Bacterial, viral also cause the endophthalmitis. CMV may also cause the endophthalmitis, but it is more common with bacterial or fungal agents. Actually, it is very rare. And how rare? All the published series, whether fungal or bacterial, or specifically in hematological disorders, or all the cases of immunosuppression clubbed, it is not more than 1 or 2 cases across the globe per year. And no study has so far specifically documented the intraocular infection, bacterial or fungal infection in the hematological disorders or patient or immunosuppression owing to the hematological treatments or post BMT. One thing is still not clear why this is so rare or why incidence is so low. Whether disease does not really occur or it is not well studied. There is a lot of issues of publication bias in these cases because the mortality is very high. Nobody published the patient gets not surviving, not living. The failure cases don't nobody like to publish. And only very old and few cases are a few case series are available where the postmortem diagnosis is also established and cases are present. So the rarity may be because of publication bias also, because since visual recovery is most of the cases does not happen, visual prognosis is poor. So this is also the discouragement. People don't publish frequently of these cases. But anyway, these cases are very rare, and that's a good thing for patient. And our experience, we have since 2021 received 1 case per year and all the 3 in hematological disorders. And all the three has been treated and doing well. I am going to discuss with you. Actually, the full talking about full pathogenesis of or full pathomechanisms of the fungal infections or bacterial infection in hematological disorders are out of scope of this discussion. But in very brief, fungal infections are most common post BMT. And with the advent of BRCI, as you know, B cell receptor, B cell, these are the newer kind of drug. B cell receptor signaling inhibitors, these are called. You may correct me. And after the advent of these drugs, invasion infections are very common. In one series, it is almost 84%. And out of 84, 54% were fungal infection, and only 30 and 37 were bacterial. So this new class of BRCI drugs, these are the episodes of infection or cases or incidence of invasive infection has increased very much, and that is also a subject of a lot of debate and publications. Actually, what do these BRCI class of drugs do? They, as hematologist, you know better than me. These all inhibit the BTK, that is the one of the type of tyrosine kinases, and that in turn inhibit the B cell receptor signaling, that is the BRCI, and through this again utilizing one of another kinases that is present in neutrophils, and this all disrupt the slow rolling of neutrophil over endothelium and reactive oxygen species release. And this means this is the disruption of innate immunity as well as second line innate immunity against fungus. And that is the main pathways so far reported or so far studies as far as this signal inhibitors drugs are coming into the fashion. Now, it is very interesting actually. What are the clinical features of endophthalmitis? In endogenous endophthalmitis particularly, because other endophthalmitis, that is the traumatic or post-operative endophthalmitis, clinical features are very much clear. Anybody, even the junior most resident, will immediately identify this is the case of endophthalmitis. But here you can see any features may present or may not be present. Okay, there is no how this endogenous endophthalmitis will present is still very much clear. Each patient in this way is unique. There may not be any features, or there may be a lot of features, or there may be a mix of features in between all. And this is the problematic. Because disease may present and clinical features may be absent. And this has the direct implication on the diagnosis and management, as you understand. These hematological patients, despite being under regular care of super specialist, often as inpatient, the prognosis and outcome of endogenous endophthalmitis is much worse than other serious form of endophthalmitis, that is post-op and traumatic. The worst prognosis is this endogenous endophthalmitis, and the only reason the disease presents in very different way, and diagnosis is very difficult. How it is difficult? Just see. Actually, it is a kind of acute event. Clinical features are very much delayed. And that means infection grow very slowly, even after well establishing itself in intraocular space. And this is responsible for the delayed referral and diagnosis. Patient is not understand, patient is not directly in the care of, he is in the hospital, but not directly in care of the ophthalmologist. He is in care of the nephrologist, hematologist. So, and how you can, as a hematologist, how you can know when the patient is not complaining anything. There is no clinical sign, there is no redness visible to you, there is no vision loss complaint to you. And this all makes the referral delayed, though infection has already comes in the intraocular spaces. And once it comes into the intraocular spaces, this is the as I told, it becomes an emergency. But here there is nothing, most of the time, nothing to say that there is anything is going wrong inside the eyes. And this all leads to the higher incidence of misdiagnosis, labeled actually very curiously up to the 63% cases in one series labeled as normal by ophthalmologist itself. Understand? They are general ophthalmologists, not retinal surgeons. And that implication I'm going to tell you. So even patient comes to the ophthalmologist, there is no guarantee that they would be diagnosed clearly and rightly. After that, diagnosis may be delayed. So you can understand why the prognosis is worst in these cases. And as a hematologist, as a physician, you must demand that patient must be seen by the retinal surgeons at the first instance, not by the general ophthalmologist. Because of the reason this the delayed diagnosis or misdiagnosis. Because actually general ophthalmologists don't see these patients or don't see endophthalmitis patients regularly. And here the presentation is very different. And it is the not only different, but in a very weird way, the presentation. So often general ophthalmologists get confused in these cases. And as I told, this all makes prognosis worse. Since patient is under your care, so your role, I will discuss the ophthalmologist part of care later, but hematologists, physicians' roles are very much important in diagnosis of these cases. How? Because you are the first to recognize something is not good, something is bad. You are the first to become suspicious of something wrong. And this will result in early referral. And whenever refer, please refer properly. You demand you ensure it must be referred to retinal surgeon, not general ophthalmologist. It may be delayed, it may be diagnosis may be delayed, or it may be misdiagnosed for a long time. And most important thing, even any ophthalmologist have seen these patients and patients are labeled normal. Do not forget for repeated examinations. Even I have listed these references. Even in the very big center in the US, patients were labeled normal at the first examination, and only it is 1 or 2 or later on, the same patient were diagnosed as the endogenous endophthalmitis. Because presentation was in such a way, and patients were not seen by retinal surgeons at first instance. It was seen by general ophthalmologist, it was seen by somebody else and somebody else. So even in the developed, the reports from developed nation and very advanced centers, this problems happens. So if even by bedside or by referral to the ophthalmology OPD or anything, patient is normal, but insist for the repeated examination if you are suspecting anything in the immunosuppressed patient or hematological patients. And as you understand, disease recognition itself is the very most important determinant of proper management. And it is the favorable prognosis, and it goes at length in reducing mortality, because there may not be fungemia, there may not be bacteremia, but there may be endogenous endophthalmitis and vice versa. Here also, Archit is here. Here also, once our patients were diagnosed as endogenous endophthalmitis, they start searching for whether there is another focus in the body or where there is somewhere else infection is running on or not, and then find something only after that. In the many of the CMV cases here also, fever was treated by antibacterial agents, and only when CMV retinitis was reported, then everybody realized that the CMV replication has been started, and the fever is because of this viral infection. So all the high index of suspicion repeated examinations, and knowledge of all these factors that diagnosis may be delayed may help a lot to you. And for anybody, ophthalmologist or retinal surgeon, for a hematologist, that is the most important determinant. I have devised this approach. This is personal experience, not validated, for physicians, in particularly in immunosuppressed patients or hematological patient or post BMT, even in remission. Red eye, you should be alert. Red eye with pain, you should be more alert. You should be more suspicious. If red eye is little bit of lid edema, it is more likely some infection, some inflammation is in the eye. And if it is associated with vision loss, then believe me, it is the more than 90% of the times it is infectious disease running inside the eye. And if all these combine, then it is almost 100% diagnostic bedside that this patient is in these circumstances, this patient has been developed some kind of infection inside the eye. But and this is I found it useful many a time. Now, people actually facing all these problems, people started into another direction. What they started doing, somebody raises that why not why we should not know beforehand that patient is going to develop endogenous ophthalmitis or any end organ disease similar to this. And they start doing this routine or repeated cultures for bacteremia or fungemia surveillance. All admitted patient or all outpatients, after a fixed interval, they start doing this thing. But and what happened? And another, but this failed actually. I am showing you how it failed. Doing repeat culture or routine cultures for bacterial infection or fungal infection won't work in deciding the end organ disease. Okay, people went one step again further. They start studying these patients, whether there are any predictive factors are present that indicate that a patient is more likely going to develop endogenous endophthalmitis or any end organ disease. That also failed actually. Actually, then people then started focusing on the ocular or end organ disease itself. Somebody said, forget it whether patient has bacteremia or fungemia. Why we not directly see the target organ routinely and start doing the fundus examination in asymptomatic patients? This also failed actually. Then this prophylactic treatment comes into the picture. And you know, the one of the etiologies frequently mentioned in your journals, hematology journals, that antibiotic prophylaxis is responsible for more number of IFIs, invasive fungal infections in these patients. This is nowadays not nowadays, but it is frequently reported. And it is listed one of the causes of invasive fungal infection prior antibiotic treatment in these patients. So this also is not any guarantee that you are giving prophylactic treatment and patient is now safeguarded from all the ills. And as I told, these are pretty unsettled issues as of now. There is more of personal choices rather than any settled standards. Just see this routine blood culture thing. Actually, only significant finding is statistical significance is immunosuppression, that is understood. Now see this one blood culture positive, 49% patients are normal. They don't have anything. And chorioretinitis, there is no chorioretinitis. So you can understand what is the value of this doing this routine culture. Okay. And this actually this non-specific is findings that mimic like inflammation or infective findings, but those are actually not inflammation or not infective. So one blood culture, there is nothing. These authors found actually when there are 3 or more than 4 blood cultures are positive, then there is the risk. But again, you see the risk is almost evenly distributed. Almost 50% patient you may expect that the disease will be present, and almost 50% may be normal. So blood culture is not going to tell anything doing routinely in asymptomatic patients. It is the clinical clues that is more important. This is very large study from United States. They just see all the patient with endophthalmitis. And when it comes to the patient with bacteremia, fungemia, and endophthalmitis, how many have left now? You understand? So most of the patient with bacteremia and fungemia, it means only 21, 22 have been developed endophthalmitis, and rest of have the fungemia or bacteremia, but does not develop any end organ disease. So at present, doing routine cultures or surveillance culture have no role in the management of these patients. Only it is the problem to the patient and burden on infrastructure. Same is the story with India. These are the Indian publication, and you just can read all the studies reports very low rate of positive blood cultures in endogenous endophthalmitis. It is from 0 to 100%. Okay. And one explanation given that all patients receive prior intravenous antibiotic as a prophylaxis. Antifungal and antibiotics are given as a prophylaxis in almost all the hematological patient. You know, you are the person who institute these treatments. Now the same story is here. Just see, the significant finding, the more number of days, the duration is only significantly associated. That is understandable. The more longer the duration of sickness, longer the more the complications, not only infective, all others. And this is again what we have talked, that was fungemia, and it is exclusive bacterial endophthalmitis, and the findings are the same, that blood cultures of no use in asymptomatic patient. Now the predictive factors. People they have studied very extensively a lot of factors in these patients, and in the hope, if any factor can predict the future onset of the end organ disease, including endophthalmitis. But what they found, though leukemia and lymphoma in these patients were statistically significantly associated, but all other factors are most of the only, if you see the older age or fungal or comorbidities along with endogenous endophthalmitis, like a patient has endophthalmitis and fungal meningitis or tuberculosis simultaneously, that is understandable. Those patients are very sick patients. Otherwise, asymptomatic patient, only leukemia, lymphoma, no doubt. These are the factors for the endogenous endophthalmitis. We are talking about this for 1 hour. And these are the statistically significantly associated with the onset of. But all other factors are not. Only thing, longer the duration of the disease, the longer the hospital stay, the more the significantly associated with the onset of endophthalmitis. Whether the risk and odds and relatives are not so there is only a trend visible, not those are not actually statistically significant in this disease also, this study also. So now this culture and all these predictive things are over. Now people started focusing on the fundus itself or any other organ, brain or whatever. This is the study. What they studied all the fungi, all the patients between 6 and 9, ocular involvement by fungal organisms. And all the patients were received the fundus examination bedside or in OPD wherever. No pediatric patient and only 2 adult patients had positive finding, that is chorioretinitis or endophthalmitis. Okay, only 2 patients out of 211. The routine fundus examination was done for a time in more than 200 patients. Only 2 patients were found to have the involvement. Therefore, this is done into the United States, and what they concluded that routine ophthalmic consultation on fungemic patients is not an efficient use of clinical resources. However, validation of these findings via prospective study is desired. So this also is no longer practiced or no longer recommended, but doing at frequent intervals or at fixed intervals of fundus examination or visit by ophthalmologist is not a bad thing. We do here. Even the in 6 patient, for our hematology colleagues, many of are you listening now? You send to us patient just for routine. If patient is admitted or patient is under care in your department, regularly you send. And that is not the bad thing. If it is feasible, it is not a bad thing, because it is non-invasive test. It is very simple. Only we have to look at the eyes. We have to look inside the eyes. And if even one case we can pick in a year of this serious disorder, this is not a bad thing actually. Now the prophylactic treatments. Actually, value of these systemic prophylaxis, whether fungal or bacterial, is not known, and all the guidelines have not been validated by vigorous studies, and the studies included are mostly case series. Few randomized trials are included in development of guidelines. And those are not actually the authors themselves accepted. Those are not of very good quality randomized studies. So what is the value of these prophylaxis treatment, empirical treatment, preemptive treatment is not known in as far as end organ prevention, including endogenous endophthalmitis. These things have to be seen into the future, what is coming out. And these are the two, these are the one for fungal and one for bacterial guidelines I found in hematological journals. And I have chosen this is from Germany, and because these are the most exhaustive guidelines. They have included most number of studies, most number of good studies. So you have to decide. You have to tell me what is the value of these guidelines nowadays. And this is the relative comparison of the primary prophylaxis, empirical and preemptive. Though primary prophylaxis, there is all patients are given the antifungals or antibacterials. The cost is the problem. It is simple to institute, simple to implement. But preemptive and empirical, it is very resource intensive therapies. Lot of expertise are needed. Lot of resources are needed. Very advanced techniques, technology is needed. That is the problem. Though they reduce the antifungal and antibacterial drugs uses very low, but problem is they are very much resource intensive. And for the endogenous endophthalmitis, now the ophthalmologist part, here the same problem. No treatment guidelines available because of rarity of disease is one factor, and another factor, the time the patient is identified properly, diagnosed properly, that is very late actually, and that time it's very difficult to treat these patients, and therefore treatment varies widely. Mostly it is the individualized treatment we are doing at present. Each center, from one center to one center, and their experiences, their past experiences, they decide the treatment mostly, rather than any standard fixed treatment beforehand. And one more thing, every patient is very unique. Just you see the BMT, post-BMT patient, the AML, ALL, all these patients are very unique. They have very different, each patient has very different kind of disease characteristic, patient characteristic. They're not, just imagine one patient is hematological suffering from also having the diabetes. So you can't fix the treatment. You have to innovate and improve yourself with each patient. Many patients, just like those comorbidities are present, patient also have meningitis, patient also have the prostatic abscesses. So usually we give after vitrectomy oral Vicilon, oral steroids for at least 1 week full dosage and later taper on. But how we will give into that prostatic abscess patient, that becomes a problem. So you can understand the treatment cannot be made common to all one pre-decided treatment. There must be some individualization in each with each patient. So there is the role of each person. Ophthalmologist care for ocular infection by medical and surgical means. Hematologist actually once endogenous as you see, many of the time endophthalmitis is present, but no other problem patient is facing. There is no other focus identified. There is no bacteremia. There is no fungemia. So if when we report that patient has this endophthalmitis thing, then hematologist also comes into the role, because eye infection has come somewhere from through the blood streams and somewhere from the other structures in the body, and that is the job of hematologist to search and identify those loci or locus from where this infection has come through blood stream inside the eyes. So systemic how since ocular infection, the nature of ocular infection, the etiology can be decided only after the culture or microscope, largely by the culture. In between that time, how the systemic infection will be controlled, it is the purely hematologist. Whether hematologist can give us a clue that somewhere else this organism has been identified, this organism has been, we found this abscess or this thing at another locus. So these all responsibilities comes to the hematologist. Hematologist and ophthalmologist both are needed simultaneously to decide the management when the need for modification in immunosuppressive therapy arises, particularly in viral infections, or sometimes in bacterial or fungal infection. Because as I said, we need to give the treatment is a vitrectomy, immediate vitrectomy, and we need to give the oral steroids or a steroid in by some route, because just to prevent the post-operative inflammation, because that will become itself a danger to the patient's eye. So in those circumstances, actually we need a very good coordination, and fortunately our center has this coordination very well established. So that may be the reason of a good outcome in our patients. And we follow this vitrectomy. We do immediate we recommend immediate vitrectomy if possible, as early as or whenever possible. This is the only treatment for endophthalmitis, and vitrectomy is done for two purposes. First of all, we must try to get undiluted vitreous samples. That is the only way to ensure what kind of organism you are facing with, and there is no other way. And vitrectomy is the only tool you can get these samples properly and undiluted. But this is the surgically demanding thing. Getting undiluted samples are not an easy thing, and this needs you understand why there is a lot of negative vitreous samples are reported, as we have seen. Even at the good centers, up to 60% of vitreous samples are reported negative. And but the issue is, it is really negative, or you have not a good quality sample, this is very important. Most of the time, what I think, it is the samples are not proper. You have drawn not a proper sample, that results in the negative sampling. And this is one thing, to get proper samples and reduce the load as much as possible, reduce the debris as much as possible inside the eyes. In that way, you reduce the bacterial or fungal load, and you are creating a space to drugs get inside the eye, and it may disperse. Because if you don't remove the pus, it is very hard. The amount injected of intravitreal microbials, antimicrobials, are very little. You need some space, and it is impossible if there is pus, the eye is filled with pus, and your antibiotics or antifungals are dispersing properly and getting it to its target to cure your patient. So vitrectomy is the only tool to treat these patients if possible, and if possible, do as early. We try to do immediately, the same day or as early. Many times we can't because of the patient problems. Patient has just imagine patient is having fever, and patient cannot be given anesthesia or many other things. So, but we recommend immediate vitrectomy. Even after vitrectomy, intravitreal antimicrobials may be needed to repeated every 48 hours for a long time. Otherwise, infection will come again. Whatever you have removed through vitrectomy, not going to be stable. And if you stop the intravitreal antimicrobials soon after the vitrectomy, this will create again a problem. Intravitreal antibiotics only, no surgical treatments, only injections as an initial treatment in the cases where vitrectomy is not possible by virtue of various factors I have told. Patient is not fit for surgery. One thing, these are usually sick patient. There may be a bleeding problem that we can't immediately take into the patient for surgery. In that cases, at least antibiotics should be injected inside the eye. So at least the infection can be controlled. If not eliminated or if not cleared, at least replication should be controlled, must be controlled. And sometimes exudates and pus is so badly filled that you don't have any space to go inside. Your vitrectomy port cannot get inside the eyes. It is so bad situation. Okay, understand? So the giving antibiotics for 1 or 2 days reduces these exudates and infection pus, and at least we can make a incision for facilitating the vitrectomy, because making incision is not possible many a time in these patients. Choice of systemic agents, it is influenced by multiple factors. One thing, by the past experiences of your centers, because culture is not culture reports are not immediately available. Only thing, KOH preparation can give the idea whether fungus is present or not, but what fungus is there, it is not clear until we get the culture report. So it is influenced by multiple factors, and sometimes hematologists are our patients getting this type of infections more in the past. So we should start this agent first hand before any culture reports come. So this is this comes out of the discussion between us. But we give oral ciprofloxacin 750 mg in every case, in each case, because of the very good concentration maintained inside the eye. The ciprofloxacin or even oral in the dosage of 750 mg BD, the very high concentration is achieved inside the ocular, inside the eye intraocularly. And this is this covers most of the gram positive as well as negative spectrum. And in the antifungal side, we use voriconazole. Hematology department gives posaconazole, but we don't. One reason posaconazole is not available for intravitreal injection. And our experience is we have voriconazole has very good response in all the patients so far we have seen. So we give oral as well as topical, intravitreal, all three routes. Voriconazole as an antifungal is preferred by us. And final therapy is started culture and sensitivity. we don't follow these three things. Though in the literature, you get the plenty of people advocating these treatments. Systemic treatment alone, intravitreal alone, or vitrectomy alone. Vitrectomy would not work if you are not giving intravitreal antibiotic later on after vitrectomy or in the absence of systemic cover. So alone, these won't work. We have all three must be combined, starting from the vitrectomy and systemic treatment, or at least vitrectomy should be done. After that, systemic treatment can be instituted if we have some kind of reports available. So, and intravitreal must be continued even after the vitrectomy till you are sure or there is evidence of infection no longer present there, or it's getting inactivated. We won't have so far whatever patient we have received. Negative sampling is not a problem. Where all the samples comes with positive results. We have identified the agent. We have identified the even species and bacterial or fungal. And it is the more the quality of vitreous samples that decides positive or negative. It must be undiluted from within exudates. That is surgically demanding thing. And surgery is not very easy to get undiluted samples from within the cavities. And if you have good quality sample, even intravitreal antimicrobials have been given prior before you get the samples at another center or by you. Even in those cases, these samples come positive. That indicates two things: that intravitreal alone cannot control these infection. Vitrectomy, removal of manual removal of the pus or infection is needed along with these intravitreal antimicrobials. And second thing, if you are getting undiluted and exudative sample, it will become positive and it will tell you what the organism you are facing with. So this is the thing. These are our experiences. And these are the newer molecular techniques, more of a research tool, and pan fungal and pan bacterial PCR. Actually, I don't believe I believe in culture sensitivity thing more, but people in negative cases people resort to this fungal. But nowadays many hospitals start from pan fungal and pan bacterial PCR. They at first, as soon as they receive the patient, they try to get some intraocular fluid and subject it to the fungal and bacterial, though people recommend it for negative cases. And this DNA sequencing or high throughput sequencing, these are the availability is an issue, and mostly it is the lab based or lab specific technique as of now. And biomarkers, based on the biomarkers and make for diagnosis or management is not successful, because most of the studies show there is no real difference between asymptomatic or normal patient and in ophthalmitis patient. The concentration is almost same in both the sites. So there is no really clinically useful information or clinically useful tool coming out of these things. The cases of the three cases. The first case was the PNH case not under remission but under treatment. And this case we received peak COVID time, so we could not image this patient. There is no photographs available, fundus or so, because in a very difficult circumstances we get in patient get inside the patient, and we were able to operate upon this patient. Because their OTs were closed, OPDs were closed, hospitals were totally closed, only COVID hospital was running, and it comes out Candida albicans, and patient is now vision was restored. Patient is leading normal life at present, and our plan, our treatment was immediate vitrectomy along with intravitreal and systemic voriconazole. This was again the patient CML under treatment, and patient was ICU in that time for some cardiac problem. And because of that, we could not image this patient also. And it comes actually here, somebody has taken vitreous tap and it came negative. So that was the reason I go for retinal biopsy. during vitrectomy. And there was no fungemia and bacteremia as in case 1. And that yielded, and it was the aspergillus. And we successfully, again, though eye was safe, but vision was cannot be restored because it is very bad infection. And most of the retina was involved already before operation. But patient is at present remission and leading normal life. This is the third patient. Still, we have received few days back. This is the B scan. Media was so opaque we could not see inside. This is the totally pus-filled vitreous cavity you can see. And again, this is the patient developed redness and lid edema and watering 25 days before post BMT at another center. The case was the BALL, and it is still under presently. We did vitrectomy, and voriconazole Ampho-B was both being given at present. But patient is actually much better after the 10 or 12 days has been passed after vitrectomy, but patient is much better. And it was the KOH was KOH shown the numerous fungal hyphae, hyphae on the KOH preparation, and so it was fungal endophthalmitis. We are waiting for the culture reports, and these are the actually published case. I have taken from published cases. This is the chorioretinitis. This is much of use of ophthalmologists rather than you hematologists. And this is the endophthalmitis. This is a candida endophthalmitis. This is chorioretinitis, only single lesion without without vitreous inflammation. And here you can see some haziness. You might not perceive it because you don't see these patients. So overlaying vitreous haziness, these patients were diagnosed as the endophthalmitis.